morning, everybody. It's 7:30 on a dark November morning. So we're really excited to have a different kind of presentation this morning. This is from all the fellows who are in the UBC Division of Nephrology nephrology program, and they're going to give us an update from the American Society of Nephrology Kidney Week, and I'll tell you a little bit more about that in a minute. Remember about the Q&A as well as the chat preferred in the Q&A that allows people to answer in case that's simpler for them. And if you have any troubles, you can contact Sidoni at the email address that you see there. Next slide. So I want to acknowledge that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and the Métis Chartered Community of the Lower Mainland region. Each of you should acknowledge the location in which you are and learn a little bit more each day about the peoples that are on those places. It's certainly a privilege to be able to do so. Next slide. So, whoops, wrong, wrong presentation. So what we've done in past is when the fellows have gone to the ASN, one of the quid pro quos is that they come back and tell us the key things that they learned. And this year, as again, was a unique year for everyone. There was no going to the ASN in Denver, Colorado, and being sort of breath at a mile above sea level, etc. But instead, each person found a way to make some time within their day or their evening schedule to register for various courses and sign up for either the online or virtual seminars. And so what we've asked each of them to do is tell us a little bit about themselves, as well as key things that they found intriguing, interesting, and wanted to share with us. So with that, I'm going to hand it over to our very capable group of fellows, and off you go. I believe the first one up is Justin, and 42 people are listening, so that's fantastic. Off you go. Over to you, Justin. If it's easier just to say next slide, you can do that. Justin, you're on mute.
Exactly. Okay. Let's figure that out. Okay. Good morning, everyone. It's my pleasure to introduce our group this morning. So here are the current fellows, and we're going to all introduce ourselves individually. So my name is Justin. I'm one of the PGY4 fellows here in Vancouver. As you can see, I did most of my training here locally. Currently, my nephrology interests include chronic kidney disease, dialysis, and transplantation. As you can see, I did engineering training before medicine. So for today's presentation, I wanted to present 3 topics at ASN that feature innovations based on basic concepts in physiology, and there are various points of becoming close to the pipeline. So I thought it might be interesting to hear about them. So the first one I wanted to talk about is the management of anemia. So in 2019, the Nobel Prize in Medicine was awarded to these 3 scientists for discovering the hypoxia-induced factors, which would be very relevant in Denver, Colorado. But essentially, these factors are transcription factors that regulate many things in the body, including endogenous EPO production and iron homeostasis. It's postulated that this leads to sort of polycythemia kind of picture for patients who either have COPD or people who are at higher elevation that are hypoxic. So currently, we already have agents that are effective in sort of abusing this pathway. So by activating this hypoxia factor, even though we're not hypoxic, they're able to demonstrate that it can manage anemia in chronic kidney disease, similar to current existing ESAs. Now, one advantage of this agent compared to existing ESAs is that because it's an endogenous sort of metabolism, patients don't have to undergo injections, and it's of a similar cost and similar efficacy to current ESAs. In terms of possible downsides, because it's involved in so many pathways, including angiogenesis, among other things, there are some concerns about safety and malignancy, and also possibly VTE events. So it's currently under study and it's currently being reviewed by the FDA. The second talk I wanted to talk to you about is about hypertension. So I think most people here would have their own approach to managing hypertension. My takeaway from this talk is always assess adherence to medications as well as measuring blood pressures accurately. So here there were two studies, one that showed 70% of patients who are supposed to be on 4 meds or more are taking no meds at all. So that definitely factors into how we manage our patients. And one more interesting study I found was that one study demonstrated 56% of normal intensive CKD patients actually had masked hypertension, meaning that they had hypertension outside of the clinic. In terms of management, going back to my concept of applying physiology to health, so Dr. Townsend postulated this model where he would measure patients' renin and aldosterone levels, even if they're not meeting criteria for primary hyperaldosteronism level, to decide what kind of diuretic is best for that patient, which I thought was quite interesting and something I'm keen to perhaps try in the future. And one more innovative factor from hypertension management is renal denervation. So they presented studies where these inventors in Europe that have this device that is definitely helpful compared to a placebo or simple to manage hypertension on one agent. Of course, this is very early in the pipeline, and this probably will never be a first-line treatment for hypertension, but I think it may be helpful eventually as adjunctive therapy for resistant hypertension or for patients who have really excessive pill burden that they can't really tolerate. And lastly, I attended a talk on hemodialysis membranes. So as we already know, even with high flux filters and HDF, our current hemodialysis modalities are inferior to the kidney in terms of removing large molecules, such as IL-6, less to an extent beta 2 microglobulins, which are postulated to be sort of pathogenic in uremic symptoms. And part of the problem of not being able to reach that is previously we had difficulty in having a narrow distribution in terms of the pore size for hemodialysis. These sort of scientists in Australia found out a new technology that will give you a very small or very narrow distribution for the pore size that will allow removal of large molecules without risking leaking albumin. So here they sort of use lambda and kappa light chains as measurements for large molecules, and they're able to demonstrate there's significant more removal in these compared to high flux filters. In terms of outcomes for patients, currently they're able to demonstrate a 12% absolute reduction in restless leg syndrome, and I think there's more studies to come in the future, and hopefully that will make us more excited to use membranes for patients who have uremic symptoms. I will hand over the talk next to Kathryn. Thank you.
Thank you, Justin. So my name is Kathryn Larmour. I went to university at Queen's University, Belfast in Northern Ireland. I'm currently renal and general internal medicine registrar in the Northern Ireland training scheme. And I am here in Vancouver as an advanced nephrology trainee from January, the programme run through the University of British Columbia. This is just a little picture of where I live on the side of Strangford Lough in Northern Ireland. Today I am going to be discussing the clinical practice session on the who, what and where for SGLT2 inhibitors in diabetes. I found this a really practical session and it helped me familiarise myself with these medications. So this first slide was from a session by Dr. Kathryn Tuttle. She was discussing how to move the trial results of SGLT2 inhibitors forward into clinical practice. She highlighted the low rates of CKD awareness amongst patients and detection in the current era, and how, really if the patients aren't aware that they have CKD themselves, what hope do we have of trying to treat them effectively? And if we're not screening, again, we're not starting from a good position. She highlighted a study that she had published looking at the medication use in CKD stages 3 to 5 in 2 large US healthcare systems, and showed that the use of ACE inhibitors and ARBs over recent years had increased, but overall remained relatively low. And in fact, we were in this population, use of PPIs and non-steroidals was more common than use of ACE inhibitors and ARBs. And in the patient group with diabetes, CKD, and hypertension, who you would postulate have the strongest indication for an ACE and ARB, the use was actually only 25%. So I found this quite striking and really felt that it was important that we get the basics right before we get excited about the ongoing use of SGLT2 inhibitors. Dr. Matt Cavender presented from a cardiologist perspective on heart failure and kidney disease, and I find it helpful highlighting the wide ranging and multiple effects of these medications on both the heart and the kidney. I'll not dwell on this, I think it has been highlighted before in the interest of time, but I thought that this was a helpful approach from Dr. David Cherney on how to use SGLT2 inhibitors and considerations along the way of the therapy. He also discussed how to avoid clinical inertia and try to move these medications into clinical practice. He highlighted the concerns about acute kidney injury safety, but showed that the GFR dip with SGLT2 inhibitors is reversible and not a sign of injury. And in fact, these medications may reduce acute kidney injury. Significant volume depletion and hypotension is rare. Blood pressure and lowering effects were modest. And in terms of glucose management, the effects of SGLT2 inhibitors and glycemia declines as GFR declines. So we should hopefully be not having to deal with glycemic control too much. And the benefits of the SGLT2 inhibitors are independent of glucose. Regarding the risks of DKA, it is rare but can be serious. And there is a risk of euglycemic DKA to be aware of. Regarding genital tract infections, these are generally mild, not recurrent and easily treated. And the UTIs may be higher in occurrence because of the underlying disease. Who should not get SGLT2 inhibitors? Well, patients with type 2 diabetes and a history of DKA, if they have frequent genital tract infections, catheterized patients, and those with a dynamic volume status or concerns regarding volume depletion, and at present in patients who are on PKD or on immunosuppression until the data is available. They highlighted sort of a good advice for patients, obviously to counsel them regarding adverse effects of diuresis, to be aware of that. And regarding the risk of genital infections, and to give sick day rules regarding sort of perioperative days and days obviously when they're unwell as well. They advocated an early review to assess for hydration status, hypotension, and any decrease in volume status, to look for the GFR dip and assess any other precipitants that could be contributing, and to check for the HbA1c, which we would anticipate a modest decline. I like this slide as I thought it was a good way to helpfully translate the data in a meaningful and helpful way to patients, in the way that they could understand, and I could see myself using it in clinical practice. And so ultimately it's an exciting time, and it's important that we educate the patients about these medications as well. And with that, I will hand over to Elena.
I'm just gonna share my screen quickly here. Oh, you have to stop sharing your screen, Kathryn. Perfect. Okay, we need to go. Sorry, everyone. I thought, there we go. All right, so I'm Elena. I'm a PGY4 nephrology at UBC. My background's in English and physics. At Simon Fraser University, I went to Queens to complete my MD there and have been at UBC for the rest of my postgrad training. My interest is in acute nephrology, including extracorporeal therapies and onco-nephrology. So the talk I chose to highlight from ASN today is one on onco-nephrology. And there we go. Looking at the renal toxicities of immune checkpoint inhibitor therapy. there's been a recent shift from traditional cytotoxic therapies to targeted agents and immunotherapies with impressive clinical efficacy, especially in certain tumor groups like melanoma. But there are some challenges that come with this, including balancing the implications for kidney disease versus cancer outcomes. When do we consider therapy cessation in the interest of renal preservation? When is the right time to re-challenge? And when does pre-existing renal disease constitute a barrier to pursuing these targeted therapies? And also importantly, is the acute kidney injury a result of the therapy or just the natural history of the disease? So this is sort of the role that onco-nephrology could play in a model where nephrologists and oncologists work closely together in a clinic. So risk factors for ICI-AKI, so immune checkpoint inhibitor AKI, would be concurrent use of drugs known to cause AIN, as the lesion that we commonly see in association with immune checkpoint inhibitors is a tubulointerstitial nephritis. So PPIs, NSAIDs, antibiotics. And this is based on an observational study that showed that 70% of patients diagnosed with checkpoint nephritis were on quote-unquote AIN med at baseline. Patients who are receiving combination therapy are at higher risk, which is not surprising. It's unclear whether or not baseline chronic kidney disease is a risk factor. There's conflicting low-quality evidence to date, so we can't really comment on that yet. And immune checkpoint inhibitor AKI occurs in around 23% of patients that are being re-challenged, but reassuringly, they respond to therapy the second time around as well, most often. In terms of the diagnosis of ICI-AKI, we know that about 15 to 20% of patients who are receiving immune checkpoint inhibitor therapy will get an AKI, but only 1 to 4% of those patients will have an immune-mediated AKI. More common lesions would be ATN, pre-renal, or obstructive. And the most common lesion that we see in association with immune checkpoint inhibitors, as I mentioned, is a tubular interstitial nephritis, and it may, in some occasions, be associated with granulomatous features. Typically, it occurs 2 to 4 months after therapy initiation, but can be as early as 1 month and as late as 6 months. And one of the common clues is that half of the time we'll have other organ involvement as well. In terms of determining with certainty whether or not it is an immune-mediated AKI, we would need to pursue a biopsy. Those biopsies are, as we know, not always low-risk interventions. So factors that would favor pursuing a kidney biopsy would be if the patient has just newly started the therapy, or if their tumor group has a high chance of responding to the immunotherapy, for instance, melanoma. If it looks as though it could be a non-immune-mediated AKI or a different type of immune-mediated AKI, so for instance, if they have proteinuria more than 1 gram per day, if they have positive serologic testing, indicating a potential proliferative lesion, if they have a clinical syndrome that suggests an alternative cause, or if they're receiving other nephrotoxic chemotherapy. And then factors favoring empiric treatments, if they fit the clinical picture expected for an ICI immune-mediated AKI, if they don't have other hemodynamic disturbances, if they're high risk for a biopsy, solitary kidney, if they're on anticoagulation, or patient preference and frailty would be considered. And this is taken from Dr. Cites' ASN presentation. In terms of management, it's pretty straightforward. You hold the immune checkpoint inhibitor therapy. You stop all the medications that can provoke AIN. And Dr. Cites has recommended that if they're on a PPI, she typically will switch the therapy to an H2 blocker. She'll switch the antibiotics and, of course, no NSAIDs. Typically, the immune-mediated AINs are responsive to high-dose steroids, so 1 mg per kg, and she starts to taper when the creatinine is about less than 1.5 times the baseline. If they're refractory to steroids, which is very infrequent, second-line therapies that have been trialed to date are infliximab, tocilizumab, and MMS, so there's really not much evidence to guide this. The key point here, though, is that giving steroids may actually affect the overall cancer survival, so it is important to try to minimize the time that patients remain on steroids for their ICI-AKI, and they can be re-challenged with immune checkpoint inhibitor therapy while they're still on their initial steroid taper, as long as they're on less than 10 milligrams of spread per day. And other lesions to keep in mind that can be associated with ICI-AKI, just based on case series, include podocytopathies, proliferative glomerular lesions, as well as vascular lesions like TMAs, but reassuringly, these still often respond to glucocorticoids with remission in nearly half of patients and partial remission in around 40% of patients. That was the talk I was hoping to highlight. I'll hand it over now.
Okay, and I will share my screen here. Okay, perfect. So good morning, everyone. My name is Wayne Hung. I'm one of the second-year trainees in nephrology, and a bit about myself. So I did medical school here in Vancouver, followed by internal medicine. Moving forward, some of my interests lie in melding the fields of geriatrics with nephrology, in particular looking at rehabilitative and palliative nephrology, as well as hemodialysis from that lens, but also from a technical and systems perspective. So I'm a bit ambitious. I have a couple of sessions I thought were really interesting to me and I wanted to highlight. First and foremost, looking at CKD-associated pruritus, which we all know is a very challenging thing to manage, something that is very prevalent and very burdensome for our patients on dialysis and with CKD, which often comes with a lot of potentially confounding contributors. We know that our current available evidence is not very effective, but hopefully with a newer and more updated understanding about the pathophysiology of CKD-associated pruritus, we may have a little bit more optimism. So I wanted to highlight our sort of new proposed model for how pruritus can be mediated in CKD populations, and specifically as a balance between opioid receptors and focusing on augmenting the activity of the kappa opioid receptor, which is able to provide sort of a dampening effect on the itch signal. And I think for me as a trainee, it was helpful to see a sort of mechanistic way of explaining why patients have this very neuropathic characteristics to their pruritus. So as you may all know, in early 2020, there was a paper published in NEJM on difelikefalin. And yes, I did have to look up a video to know how to pronounce that, but as a peripherally acting opioid receptor agonist, which is shown to be effective in reducing itch intensity as well as improving itch-related quality of life. Currently in its form, it's a IV medication that's administered 3 times a week on dialysis, but there are studies going on to look at oral formulations as well. So we'll keep our fingers crossed that we'll have some more effective therapies coming down the pipeline. The next session I wanted to highlight, I thought was just really cool as a sort of primer into what exciting work is being done to see how else we could perform renal replacement therapy. And I did not even know this existed before, but xenotransplantation. So using animal-derived kidneys as a way to try and bridge the gap between long wait lists for transplant and a small donor pool. And I think it's intriguing, certainly from a philosophical and ethical perspective, but also they describe quite a lot of immunologic and infectious and sort of genetic considerations they've had to navigate as well to try and make it happen. Where they are currently is transplanting these genetically engineered pig kidneys into baboons. And they've seen anything, ranging from hyperacute rejection to grafts that last months and months and months. So I think it's still early days, but if we're using tissue valves from, pigs and cows, I don't think it's a stretch to think about animal-derived kidneys as well. And then on the other end of the spectrum, we also have really cool ongoing sort of basic benchtop groups who are looking at using stem cell technologies to either try and regrow small kidney organoids or using fetally or urine-derived stem cells that they then induce and inject into kidneys to try and repair injury. And again, it's also very early, but hopefully as the field develops, we'll see if there's any utility for this kind of therapy. From a vascular access perspective as well. There are some groups that have looked at using collagenous decellularized grafts that are made in vitro or in vivo as a way to find another source for customizable, ready-to-use, non-synthetic grafts for conventional dialysis. And so I thought that was very cool. And then finally, there's the kidney project, which I think has made its way into more popular mainstream media, and something that I think patients have asked about before. Can I get that tiny little kidney box? And so they don't yet have a working prototype, but they've done a lot of good work so far. And where they stand is they have a device that is designed to contain two parts. So one is a hemofilter, which they've done a lot of work to sort of miniaturize our existing filters into a more nano scale, but to also add on a hybrid bioreactor, which is essentially kidney tubule cells that are lined with the hemofilter to theoretically provide tubular function. So at this point, they've demonstrated the utility of the hemofilter on its own. So you can see in the bottom left corner, they've implanted into pigs and demonstrated that they're able to achieve consistent clearance. But you know, at the speed that technology is moving, I'd be very excited to see where this goes as well. And then finally, more so for personal interest, but I also thought it was pretty eye-opening to catch a few of these sessions on patient-centered interventions in hemodialysis. And specifically, very busy looking slide, but this is from Dr. Connie Ree's presentation, which captures, you know, our challenges in transitioning patients to dialysis. We know that it is a very high-risk period for patients, but it is just so intricate. You know, there's so many questions that you have to try and answer to decide what is the optimal way to transition people to dialysis. What's the timing? What's the format? What's the frequency? What's the modality, the location, the access? And I think despite everything we do currently, we still see patients who either have unplanned starts and or suboptimal and or crash starts. So I think this is where the concept of incremental dialysis comes into play, not only as a way to align ourselves with patient wishes, but to also realize the increasing body of evidence for residual kidney function preservation, not only in PD patients, but also in hemodialysis patients. And I think this diagram very neatly illustrates the sort of difference between the more rigid 3 times a week conventional dialysis model versus one where you're doing incremental and then maybe intensive dialysis for patients and palliative or decremental dialysis for some patients as well. And certainly from a trainee perspective, it's, I think, very eye-opening to see that we can be very malleable with the way we do dialysis, which can not only improve clinical outcomes in terms of residual kidney function, but also in terms of aligning our therapies to patient wishes. And I know this is something that we already do in BC, and so I'd be very excited to see where this goes. And I will hand the presentation over to Lachlan.
All right, hi everybody. So my name's Lachlan McMichael. I'm originally from Adelaide in Australia, and currently working here in Vancouver as one of the advanced nephrology trainees. And majority of my training's been at the Royal Adelaide Hospital as one of the College of Physician trainees there, having done my university there as well. And my main interests are predominantly in investigating access to transplant and patient progression through to waitlisting, and also quality and safety in healthcare. So in terms of the presentations I thought I'd focus on today, the first was a session on obesity and transplantation, and this is an area where I've done a little bit of work back home investigating this, which is certainly a big issue for us in Australia and certainly in North America as well. And as most of us will know, there's high and certainly increasing rates of obesity worldwide, and We know obesity is associated with faster progression of chronic kidney disease, and certainly we do expect to see higher numbers of patients who will be presenting for assessment and consideration of renal transplantation, and we'll be expecting higher rates of patients that have obesity and who are overweight that are going to need to be assessed. And certainly from my work back in Adelaide, this was seen as one of the largest barriers in patients presenting for transplantation access to them actually being waitlisted, and I'm sure there are similar rates over here in North America and particularly in Canada. So in terms of the presentation that was at ASN, they certainly reinforced the issues in assessing these patients because people come in quite different circumstances, and they don't all present as a similar obesity phenotype, and reinforcing the difficulties in actually assessing these patients as to what the risk-benefit analysis is in progressing to transplantation. One of the biggest points that they did make was that BMI in itself is certainly not a way that you can really typify obesity assessments, and that a broader sort of picture of a whole patient needs to be analysed, which I think at this stage we probably haven't progressed to in transplant assessments. And in the majority of centres, there's no real streamlined pathway on how we should be managing these patients, and there was certainly discussion about trying to work through a process so we actually can have a more streamlined assessments of these patients. And certainly reinforcing that we all hold our own biases towards some of these patients as well, and that might influence the way that they're managed and treated in their progression through to transplantation. The second session that I also looked at was looking at pregnancy and end-stage kidney disease, and the session mainly focused on pregnancy and transplantation, but also did look at pregnancy in patients with chronic kidney disease and patients with dialysis dependent kidney disease. And obviously this is a very complex area and is a very, I suppose, a very niche area. What I found quite interesting from this discussion was that interestingly, the rates of pregnancy were actually higher in dialysis patients than transplant patients, which I found, which was in one of the observational studies that this group had performed, and I found that quite surprising. Certainly the rates of live births was a lot less in the dialysis patient group, but certainly I think not something that we routinely think about in our dialysis patients, and there was a lot of discussion about talking about contraception and family planning, both in CKD patients and dialysis patients and transplant patients, and probably an area that we as a field probably need to be cognizant of in patients that are of childbearing age. So that was certainly an interesting take-home point I had. And then there was further discussions about the need for obviously a comprehensive multidisciplinary care structure for patients who are considering pregnancy and who are pregnant, who either are transplant patients or dialysis patients, and they need obviously very close intensive follow-up during that process to optimise outcomes in pregnancy. And the last session I chose to focus on, which I think is something that we commonly see, it's probably not an interesting, sexy topic with lots of new treatments that are being proposed, but certainly something I think that we all find very difficult to assess and manage, and is a really common thing we see in the hospital. And certainly not having been in a liver transplant centre before and now working in a liver transplant centre, I've seen a lot of it so far in my 2 months here. I think the reassuring point I got from this talk was one that they reinforced how difficult it is to assess these patients, and particularly looking at AKI in the setting of patients with cirrhosis. Teasing apart the hepatorenal syndrome from ATN and other causes of acute kidney injury are extremely difficult, and even hearing from the top experts in this area, they've further reinforced how difficult it is to manage these patients, and rarely is it a pure dichotomous sort of HRS versus ATN versus other causes of AKI. They did focus on some of the studies that are currently being performed to add terlipressin to use in North America, which we use a lot of in Australia. So it'll be interesting to see where that progresses, but so far that hasn't had FDA approval. And they also reinforced the focus on conservative pathways for patients who are not transplant candidates, which I think that we well know, but I think it's also helpful to hear that reinforcement from some of the eminent experts in the field of hepatorenal syndrome. Thanks very much. I think I'll hand over to Shannon.
everyone. So my name is Shannon. I'm one of the first-year nephrology trainees. My background, obviously, I did my medicine here at UBC. I'm interested in the integration of palliative care with home therapies and feedback in medical education. And here's a cute little picture of my cat that I adopted in quarantine. In terms of the talks that I chose for this presentation, they weren't really things that were related to my interests, but more so things that were relevant to what I was seeing on clinical rotations at the time. So the first talk that I attended was novel therapeutic options in hyperkalemia. So one of the trials I want to highlight was called the Stop ACE inhibitor trial. It showed the association of different patterns of pre-dialysis ACE and ARB use with hyperkalemia and post-dialysis survival. So on the left-hand graph here, you see the risk of hyperkalemia is increased across all levels of ACE and ARB exposure. But interestingly, the risk of severe hyperkalemia, which they defined as a K of greater than 6, was not increased in groups with the highest level of ACE or ARB exposure, as seen in the orange and the gray bars. On the rightmost graph, we can also see that higher exposure, uninterrupted use of ACE or ARB inhibitor, or ACE or ARB, was associated with lower all-cause mortality. Given the benefits of ACE and ARB use, it's important to talk about how to manage the associated hyperkalemia. So as we know, we're all familiar with sodium polystyrene sulfonate. It's a non-specific exchangeable ion. The time to effect is actually not well studied. I didn't realize it was only studied for as long as 7 days. And as we now know, it is associated with colonic necrosis. Patiromer is a relatively new medication that exchanges potassium for calcium. The initial effect occurs at 7 hours and it's associated with GI side effects. The AMBER trial has also shown that it allows continuous MRA use in patients who have resistant hypertension and CKD. And finally, sodium zirconium cyclosilicate is the newest agent. It exchanges potassium for sodium and hydrogen. It's rapidly effective at 1 hour and its long-term use does have sustained reduction in potassium level. There are no GI side effects, but it can lead to edema because you are exchanging sodium. And so far, there are no hard outcomes regarding mortality benefit or reduction in heart failure hospitalizations, which is primarily why these are not first-line treatments right now because they are quite expensive. So I think the takeaway points from this presentation are that hyperkalemia does occur when patients are on ACE and ARBs, but it's important that we don't discontinue these medications immediately when we encounter high potassium levels because they have many beneficial effects, some of which are seen, for example, in the Stop ACE inhibitor trial. And it is reassuring to know that there are medications coming down the pipeline to help us manage the associated hyperkalemia, and hopefully there'll be some harder data outcomes to follow. The next talk that I attended was called Lupus Nephritis Emerging Therapies. Just as background, there was a trial called LUNAR, which looked at MMF and rituximab versus MMF and placebo in lupus nephritis patients. They didn't actually see any significant difference in renal response, but from the perspective of B-cell depletion, rituximab showed significant B-cell depletion at week 52. So it kind of suggested that there actually might be a role for B-cell therapies, but that we need longer trials to determine if there's any effect. And so there are 3 new medications that kind of came out of that idea of these B-cell therapies needing more time to see if there is an effect. One of them is called obinutuzumab. It's an anti-CD20 monoclonal antibody. In the NOBILITY trial, patients received MMF and methylprednisolone as induction, and they did see that there was a significant difference in renal response in the obinutuzumab group compared to placebo. And it did take about 6 months to see those curves separate. And there was no increased adverse response or adverse effects in the obinutuzumab group. In the belimumab group, which is a monoclonal antibody against B lymphocyte stimulator, in the BLISS lupus nephritis trial, patients were randomized to induction with MMF and steroids versus cyclophosphamide and steroids, and they did find that the belimumab addition to standard of care therapy showed significant difference in renal response. Similarly, the curves started to separate at the 6-month mark. And then finally, voclosporin is a small molecule calcineurin inhibitor. In the AURORA trial, patients received induction with MMF and methylprednisolone, and they did also see that there was a significant increase in complete renal response in the voclosporin group compared to placebo, and this effect was particularly predominant in Asian and Black patients. The presenter suggested that these medications may be considered in the following ways. So voclosporin could be considered in patients who had evidence of significant podocyte injury, well-preserved renal function with minimal chronic changes on biopsy. And these B-cell therapies might be considered in patients who have impaired renal function and modest chronic changes on biopsy. I think the key takeaway point from this presentation was that there is an emerging role for these new B-cell therapies, but to be cognizant of the fact that that effect may take several months to years to observe. And it'll be interesting to see how these medications fit into our current landscape of how we manage lupus nephritis. And finally, I attended this talk called High Impact Clinical Trials. I decided to highlight one trial that didn't get as much press as Fidelio or DAPA-CKD this year. So this was called the RICH trial. It examined the effect of citrate anticoagulation versus heparin for patients on CRT. The authors hypothesized that citrate for CRT would increase filter life and decrease mortality in critically ill patients with AKI compared to the use of systemic heparin anticoagulation for CRT. In terms of outcomes, they looked at filter life and 90-day all-cause mortality. As you can see here in blue, this represents citrate and represents heparin. Citrate led to a longer dialysis lifespan, but there is no difference in terms of 90-day mortality when compared to heparin. As well, in terms of the adverse events, there was less bleeding noted with citrate, but there were increased adverse metabolic complications and a higher infection rate in the citrate group. I think the key takeaway points here are that citrate anticoagulation can lead to a longer dialysis filter lifespan, but there is no mortality difference when compared to heparin. So I think therefore citrate use in CRT has to be carefully weighed against the significant metabolic complications, including hypocalcemia, a potentially higher infection rate, as well as higher nursing requirements in a critical care setting. And that's it. Thank you so much for your time.
So I think you'll all agree that that was a whirlwind, but fantastically well presented. Kevin, is it your turn? Sorry.
Yes.
Oh, sorry. I got,
one more person to go here by the alphabet.
Go, Kevin.
So I'm Kevin Zhang, one of the PGY5s or second year core fellows. I did medical school here in UBC and my internal medicine in Edmonton. I'm interested in community nephrology and peritoneal dialysis. I kind of focus on the dialysis pre-course during the ASN, as well as lectures related to PD. And first, I'll share a bit more about the vascular access part. This is a series of talk about personalizing care and dialysis vascular access. And really a key focus of that was the new KDOQI 2019 guidelines. And really the emphasis here was really a shift in focus from this, gospel of fistula first, catheter last, which I read in the dialysis handbook as a resident, to more focusing on individualizing the dialysis access needs of the patient with the ESRD life plan, and the key emphasis on the right patient, the right access, the right time, and for the right reasons. So I think a lot of the shift in this, and having seen the BC Renal pamphlets that we give patients, we do kind of emphasize a lot about the fistula first focus from the last guidelines, which I think were back in 2006. But really, there's more evidence now that the thought about fistulas having longer lifespan and patency compared to grafts, that if you take into account into failure to maturation of fistulas, the grafts don't really fall behind that much at the 2-year mark in terms of patency, and that fistulas that need extra interventions to continue to have patency kind of increase the cost, especially if they needed assistance to mature. So compared to grafts, fistulas do have some advantages in terms that if they do mature, they last longer and require less interventions. But we all know of patients with quite problematic fistulas requiring repeated interventions. Kind of a highlight of this was the grafts are not that far behind and could potentially have additional advantages. And having training here in Vancouver, I do definitely see fistulas a lot more than grafts in terms of experience, but there's data out there to show that grafts can be cannulated much earlier than fistulas. There's trial about cannulating grafts within the first 72 hours of insertion, so that patient can potentially avoid a catheter altogether. And in some data, 78% of grafts were cannulated within the first month compared to 2% of fistulas. So I think there's definitely areas to look at there. And definitely, again, it's not what we're not doing this already, but it kind of lays out this ESRD life plan about planning the pre-dialysis patient or the failing transplant graft patient. Are they a PD or hemo candidate? What is their trajectory looking like for transplantation? Do they have a living donor? And really shifting the focus to be less prescriptive, fistula first, and considering the independent needs of the patient in more detail. As part of the dialysis pre-course, something I found really quite interesting, was quite an eye-opener for me, was a debate that they had between Dr. Timmy Lee and Dr. Moist in Western University about whether we should be surveying fistulas with flows like the transonic that we prescribe Q monthly for our patients here at VGH. You know, what is the evidence behind that? And really the new Kadoki guidelines continue to say there's insufficient evidence to really support the use of surveillance. And I think before we go on, one thing that is kind of ingrained to me was really defining monitoring as opposed to surveillance. Monitoring is physical examination and looking for symptoms, which we should be doing in every patient. And these more fancy technological advances, such as doing the transonics that we do for our, and flow monitoring that we do for our patients, is there really an advantage to doing that? So some of the arguments they made were that do all subclinical stenosis that don't have symptoms lead to thrombosis? And I don't think we can confidently say that that is the trajectory for all fistulas, as well as the studies that looked does suggest some evidence, but there were upwards of 80% more procedures done. So does the cost actually outweigh the benefits that we're seeing in patients? And again, a lot of this surveillance discussion is on fistulas. Actually in grafts, there's no evidence to support the use of surveillance monitoring. So really it was kind of eye-opening to me, because I kind of took it forward that we should be surveying everyone based on our practices and getting calls about flows from the hemo nurses. So this was something definitely to think about before I order the next IR angioplasty on my next patient. Of interest, there's some newer research out there about paclitaxel-coated angioplasty balloons that are seen more effective than standard balloon angioplasty. So there may be even better treatments out there available for if we do identify these stenoses. Another talk I'd like to highlight is the peritoneal dialysis outcomes to increase its use. Again, there was emphasis about shifting the focus from KT/V measurements to patient-centered goals and quality of life. Dr. Philip Lee in Hong Kong discussed advances in PD peritonitis. And what I like to highlight is there's increasing novel methods that are out there to identify PD peritonitis. So this almost looks like a pregnancy test here on the right, but what they've been looking at more recently, this is in the UK with 100 patients, is looking for testing the dialysis effluent, where within minutes you can get tests for some cytokines and pro-inflammatory markers like MMP8 and IL-6, and they actually had a negative predictive value of 98% for identifying PD peritonitis in the 40 of these 100 patients that actually had peritonitis. So there's some thought about potential use of this, whether there could be a point of care testing, or patients could do this at home to give us additional information over the phone. So that's kind of food for thought there. And lastly, they also highlighted the SOM PD initiative, which are patient and caregiver and physician and multidisciplinary-led initiatives about identifying key core outcomes relevant to PD. And lastly, I'd like to highlight there is a talk from Dr. Ito from Japan, so where they have over 67% of their incident ESRD patients being over the age of 65. And he kind of shared some experiences there in Japan about how they handled that volume of patients. This is a kind of Google map picture of Nagoya City where he practices, and all these points in red here are actually satellite nursing units that can help with home PD assistance. So it's kind of interesting, they do have both private and public models in Japan to support and financially fund this, but they could potentially go in 4 times a day to help patients with exchanges here. So how applicable is that to our practice here in British Columbia? We're having taken care of some patients in Yukon, and also recently spent some time in Kamloops, taking care of a PD patient a few hours away from Kamloops, where they don't have the same density of population, is definitely another food for thought about how we can implement PD assist in a more dispersed population here in British Columbia. So with that, those are kind of some of the highlights. So I kind of thank you everyone for tuning in and sharing this morning with us and listening to the fellows and what we learned. So we'll give it back to Dr. Levin here.
Thanks. So I'll say what I started to say. What a fantastic overview. I gave them a task of 4 slides. They got mad at me and said I wasn't allowed to, they had to do it in more, but I think you did a great job of synthesizing super high highlights. I feel like I didn't get a chance to go to any of the ASN except one talk, so I feel like I've just learned a lot. I think I would share that you had about 54 people at the height of all of the things, so that was really great. Everyone's commenting about what an excellent overview it was. I am curious a little bit in terms, I had not appreciated the different half-lives of the potassium binders, and thinking about onset of action if we were to use them in the hospital. So first of all, I think they're mostly for chronic use, but second of all, Shannon, like just if you think about the SZS, then perhaps since it has a rapid onset of action, we might think if we were to use it, we would use it in acute in hospital settings if we were not wanting to shift people. Was that your impression when you were talking, or not particularly?
So the impression I got was that the sodium zirconium cyclosilicate actually works the fastest because the onset is 1 hour. And the interesting thing I thought was SPS, we actually don't know what time it takes to affect because it just really wasn't studied very well, and it wasn't studied over a long period of time. So I thought that was quite interesting. But then I looked at what costs there were available on UpToDate, and like for example, for patiromer is 8.4 grams is like the average dose. It's like $40 US, I think, for 1 dose. And then for the zirconium, I think it's 10 grams every 8 hours that they recommend, and 10 grams is about $30 as well. So that, unfortunately, I think is the main prohibitive factor right now. But it is interesting to see that it actually is effective over such a short timeline, but we can't use it in that way quite yet. Yeah,
I think all of you presented interesting things that we could think about how we do things today and how we might want to do things in the future or study them in a little bit more proactive way. Any other questions? I know it's hard with 47 people left on the phone and 2 minutes to go, but really that was outstanding, everybody, really. Excellent. And the slides are, this talk is available on the Renal Agency website. So it's there in perpetuity if you want to go back. You also, I want to compliment you, you presented beautifully. Succinct, clear, excellent slides, and really the kernel of what you all learned. So that was really terrific. Everyone's commenting in the chat box if you want to see. So really, and I also like that we all now know what you look like with and without your masks. So we will make a montage of that set of things as well and be able to distribute it to all the different areas in the province, as well as being on the website. So thank you all very much. Bravo.